So welcome everybody, and thank you for staying with us for most of the day. My task today is to talk about preventive medications in migraine. I'll just start off by showing some, my conflicts of interest. I do a fair bit of work with industry, as you can see. The drug industry is where a lot of the research on headache is going right now, and so it's good to be a part of that and keep up to date. Our objectives, we'll discuss who needs to consider migraine prevention. Then we'll discuss which migraine prevention medications should be considered and when. I'm going to start off by showing a quotation from Benjamin Franklin. Benjamin Franklin said this about 300 years ago: an ounce of prevention is worth a pound of cure. Now in Canada, of course, we're metric, so maybe I should say 50 grams of prevention are worth a kilogram of cure. But Benjamin Franklin was talking about fire prevention in the city of Philadelphia. So does any of this apply to migraine? So you've heard a lecture already today, those of you who've been on the program all day, about acute migraine therapy. So in a way, the way you use water and a fire hose to put out a fire, you could say that taking acute medications for a migraine attack is kind of a quotation marks cure for the migraine attack. And that cure could be acetaminophen, or better yet, NSAIDs, or even better yet, a triptan. However, if you put water on a fire over and over, of course, you do a lot of damage, and you really can't take these acute medications too often, or you may get into what was mentioned earlier in this day, a medication overuse headache from taking these acute medications too often. And that too often is usually about 10 days a month or more. So it's important to consider migraine prevention. And migraine prevention is really a pretty complicated thing. There are at least three ways to look at it. Number one are the behavioral methods, and you've heard that today already from our psychologist and from our kinesiologist, and also from our dietitian, that you can make lifestyle changes and learn about stress management and improve your sleep and exercise, and that may help you reduce the number of migraine attacks that you're suffering. You can also try some minerals or vitamins or some herbal medications. And then there are the prescription medications, which we'll discuss in more detail today. So when it comes to the behavioral aspects of migraine prevention, who should try them? I would say everyone. Everyone with migraine should learn some behavioral strategies, learn about lifestyle and stress management and exercise, and help to make themselves less migraine prone. When it comes to the minerals and vitamins, well, the big ones there are magnesium and riboflavin, vitamin B2. Laura McLeod was a little bit, I think, circumspect in terms of who should try magnesium. I would think that if you want to use magnesium citrate to prevent your migraines, this is available in the drugstore over the counter. It's probably perfectly safe for almost everyone to try this. I wouldn't start with a full dose, 300 milligrams twice a day. I'd begin with 150 milligrams a day and gradually build up, because some people do get quite loose bowel movements, and that can be a problem. On the other hand, if they're constipated, then that's a good thing. And magnesium citrate generally has very few side effects. And in fact, apparently in North America, most of us are somewhat magnesium deficient anyway. Riboflavin, the dose here is 200 milligrams twice a day. Again, this is available without a prescription. And that's quite a big dose in terms of nutritional needs. It's much more than you need for your regular nutrition. The main side effect really is orange urine, which doesn't bother most people too much. You should probably avoid these high doses in pregnancy, but otherwise, we see very few side effects with riboflavin. Moving on to the herbals, the most effective one is probably butterbur. This is a complicated thing. Laura McLeod mentioned that the plant that you get butterbur from contains liver toxins that must be carefully removed before it's taken as a medication. The fact of the matter is that although these are considered herbals, they really are drugs. But the problem is that whereas drugs are very carefully regulated in Canada and in the United States, these natural medications are not so well regulated. So many companies sell Butterbur. They don't necessarily all have the toxins removed as carefully as they should. And in fact, they don't even all contain as much Butterbur active component as they should. So I don't often do this, but in this case, I'd recommend that if you want to try Butterbur, then you should find a product called Petadolex. And that's a trade name because there is evidence in the medical literature that that compound is produced safely, the liver toxins are removed, and it's got what it says it has in it. Now, other companies may have just as good a product, but they haven't objectively proven, as far as I know, that in fact it is safe. And we do know that Petadolex is safe and has the right stuff in it. So it's complicated, and maybe for that reason, Butterbur is best avoided unless you can be sure you're getting the right thing. Now let's go on to migraine oral preventive medications. These are prescription medications. And the question is, who should try these medications? Not every migraine sufferer needs a preventative medication, but here's a bit of a guide as to who should consider them. Broadly speaking, one could say that any migraine sufferer who's taking a good acute medication and who has paid attention to lifestyle strategies, if their migraine attacks are still having a significant impact upon their lives, then they should probably consider a preventative medication. If you want a number, well, if you have more than 3 moderate or severe headache days a month and acute medications aren't working that well for you, you should again probably consider a preventative medication. Finally, another number, if you're having more than 8 headache days a month, even if your acute medications are working really well for you, you should probably still consider a preventive medication because you're getting close to the limit as to how often you should be taking the acute medications without risk of developing medication overuse headache. So you don't want to go over 10 days. So 8 days is kind of a bit of a watershed where you should consider prevention, even if your acute medications are working really well for you. So a few things. First of all, these preventive medications need to be taken every day, and that's important, even when you haven't got a headache. Some people tend to miss them, and then they won't work as well. For most of them, you begin with a small dose and you gradually build up. And furthermore, they don't work right away. It takes about 2 months before you know what it's going to do for you once you reach the full dose. So you don't want to stop too soon. And if you're having some mild side effects, it's best to try to ignore those and carry on and see how much your headaches improve, because the side effects may improve as well. If you're having a real problem with side effects, then it's time to try something else and stop the one that you're taking. And we're not talking dangerous side effects. We're talking about things that are unpleasant, like nausea, dizziness, sedation, those sorts of things. Unless you're having significant side effects, if you are going to stop your preventative medication, it's best to stop it gradually, the same way that you started it. So what can you expect? Well, I mentioned that it won't work right away. It takes a while to benefit you. It likely will not stop the migraine attacks completely, and usually a reduction of 50% or more in your migraine frequency is considered worthwhile, and the medication is continued. And you may have other benefits as well. For example, your attacks may become milder, or they may respond more completely to your acute medication. This graph just shows you what to expect from an oral migraine preventative medication. This is topiramate or Topamax, and I'll just draw your attention to the top blue line and the bottom green line. And along the top there we have months, and along the vertical axis we have change in headache, that is reduction in migraine attacks per month. And you'll notice that although the placebo has some effect, the headache days have gone down a little bit, or the headache attacks. The green line shows a much larger reduction in migraine attacks per month, but it's not there at month 1. It takes until about month 3 before you can see exactly what this medication is going to do for you, at which point the improvement starts to plateau and remains fairly constant after that. So here's a list of some oral migraine preventive medication, and you'll notice that the beta blockers, the most commonly used one on propranolol, is there. And we have amitriptyline and nortriptyline. These medications are all used frequently as a first medication for a migraine sufferer who wants to try prevention for the first time. As you can see, they're built up gradually, week by week, until you reach a so-called target dose. With the amitriptyline, usually you get to about 30 milligrams, and most patients don't want to go much higher than that. With the propranolol, it's quite variable, but patients can be taking anywhere from 400 to 120 milligrams. If you go down the list there, you'll see topiramate. Again, it's started slowly, 25 milligrams once a day, built up week by week until you're taking usually 50 milligrams twice a day. We have candesartan there as well, which is a blood pressure medication, which generally has few side effects and can be helpful for quite a few patients, although it's less well established in terms of proof of effectiveness than the other medications. So the list is quite long, and the trick is to find one that works for you. Now, there are more as well, and as you can see here, there are 4 more oral migraine preventive medications. I'll just draw your attention to Venlafaxine, which is an antidepressant medication. It's been shown to help quite a few migraine sufferers in terms of their migraine. It's also good for depression and anxiety. So if you have 2 or 3 of those conditions, then this might be a good medication for you. But the oral preventive medications aren't perfect. And what I'm showing you here is data from a study that involved over 230 patients. Now, the point is that these medications were helpful. They took basically a variety of oral preventive medications. A few were taking Botox, but only a very few. This is mainly oral preventive medications. And what you can see is that overall, for the group, the average headache days per month went down from 14.7 days to 9 days. So these medications had quite a significant effect upon their headache frequency. But you'll also see in that second paragraph on the right-hand side that over a third of patients had stopped the medication within the first 6 months. And the reason they stopped is because about 2/3 of those patients were having side effects, and they didn't like those, and they thought they should stop the medication. Another 22% felt the medication really wasn't working for them. That's why they stopped it. And in fact, only about 8% in this group that stopped the medication had stopped it because they felt they were just so much better. So side effects and medication not working, these are significant problems for the oral migraine preventive medications. So what other options are there? And I've listed 2 things here. One is onabotulinumtoxinA, also known as botulinum toxin, or the trade name is Botox. That's something probably that most of you have heard of. This is used only for chronic migraine. That means migraine with headache on at least 15 days a month. And then there are the CGRP mAbs. Now, CGRP is shorthand for calcitonin gene-related peptide. This is the molecule that's involved in the pain system, and it's involved in the generation of the migraine attack. Now, the mAbs part stands for monoclonal antibodies. So these are antibodies. These aren't the usual small molecule drugs. These antibodies come in, and their job is to basically wipe out the CGRP so the pain system can't produce a migraine attack. So let's discuss the Botox in a bit more detail. And what I've shown you here is the injection paradigm. The bad news is that patients who receive Botox or botulinum toxin need to receive over 30 injections around the head and neck and the shoulders, as shown here. The good news is that this only has to be done every 3 months, so it's not all that often. And also the good news is that this medication stays pretty much where you inject it so that it doesn't go around the whole body, and therefore people tend to have very few side effects from it. Is it helpful? Well, here's a study which shows that with the first treatment cycle, shown by the first tall bar there, about half of patients will have a reduction in their headache frequency, their headache days per month, of about 50% or more. So that's not a bad response. With the second injection cycle, you'll notice that another 11% have a reduction in headache of 50% or more. And with the third injection cycle, now we're talking 3 months in between these cycles, that 10% more patients get this response of a reduction of 50% of their headache days per month or more. So it sounds pretty good. Now, this is used only for chronic migraine. Let's talk now about the CGRP monoclonal antibodies. And we have 4 of them, which I've listed here. The first 3 are injected subcutaneously under the skin, usually once a month. But in the case of the third one, fremanezumab, it's injected. It can also be injected in a larger dose every 3 months. The fourth one, eptinezumab, has to be injected intravenously, so it's a bit of a bigger deal, but only once every 3 months. So we have these 4 antibodies that whose job it is to shut down the CGRP molecule and thereby prevent migraine attacks. Now, these medications are not available in oral form, and so they have to be injected. This is a picture of what sort of happens with these. And you can see that the 3 of them, eptinezumab, fremanezumab, and galcanezumab, these all basically work by binding the CGRP molecule that the nerve endings release and basically immobilizing it. The fourth one, erenumab, also called Aimovig, its job is to attach to the CGRP receptor itself, and in that way, it blocks the CGRP from doing what it does normally in the pain system. So that's kind of the science behind all this. I'll just show you one graph here. This is from fremanezumab or Ajovy. And as you can see, here we have the percent of people who have a 50% or more reduction in their migraine days per month. This is for chronic migraine. And you'll notice in the big brownish orange bar there that over 40% of patients had this reduction in headache days per month. Whereas the dark bar is the placebo group, and it shows that quite a lot less or fewer patients had that reduction in headache days per month. I guess you can see right away that this medication doesn't work for everybody. It works very well for some, moderately well for others, and for some it hardly works at all. So it's not a perfect medication, but it certainly helps a lot of migraine sufferers, as do the other 3 of these CGRP monoclonal antibodies. They're a useful addition to our migraine preventive treatments, but they don't help everybody. So if we summarize that, what about these new drugs, these new antibody drugs? Well, again, they don't work for everybody, but they can work very quickly. In fact, the IV version, eptinezumab, works within a day, actually. And they all work pretty fast. So you don't usually have to wait as long as you do with the oral medications, although you may have some further improvement after the first month or 2 as you keep on going. Importantly, they have very few side effects for most people. In fact, in most of these clinical trials of these medications, they didn't have more side effects than the placebo. Although, as we've used them more and more in the general population over the last number of months, some side effects do pop up. Some people even get a severe allergic reaction to them. But that's uncommon. And so the big strength these medications have is that they have really, by and large, a lot fewer side effects than the older oral preventive medications. So that's the good news. The bad news is that they're expensive. They generally cost over $600 a month. However, they are an important advance in migraine prevention because they work well for a significant number of people, and for most people, they have very few side effects. I'm going to close off with a final little thing, and this is about devices. There's more and more research being done into non-drug migraine prevention, and I guess you could say non-behavioral migraine prevention. And this has to do with electrical or magnetic stimulation. Now, the first thing you see there in the top is the Cephally device. This is a device that's available in Canada, and it basically stimulates the nerves above the eyebrows, and has been shown, if it's used for 20 minutes a day, every day, that it can reduce migraine attack frequency in some people. The second device there in the middle of the slide is the single pulse transcranial magnetic stimulation, or STMS device. This doesn't use electrical stimuli, it uses magnetic stimuli. It's not yet available in Canada, but hopefully it's coming in the not too distant future. And the lower one, again, is electrical in nature. It is available in Canada. It's the Gammacore Sapphire device. Now, this device is meant to stimulate the vagus nerve in the neck. The usual protocol is 4 minutes of stimulation 3 times a day on one side. And this again has been shown to produce a reduction in migraine headache frequency in some patients. So with that, I'll stop and I'll just put my conclusions up for you to look at. The point is that there are many options for migraine prevention, everything from drugs to antibodies to prevention, to minerals to herbals. And for those with frequent migraine attacks, they really should consider these. And if the oral medications aren't working well for them, they should consider the newer injectable options.
Awesome.
And
thank you. Thank you, Dr. Becker. There's several questions that have come in. So thank you. And please keep emailing your questions in. The first question was actually about the combination of Botox and CGRP medications. Is there evidence, and is this something that can be done?
So it can be done. And the evidence is slowly coming in that it is helpful for some people. It's, of course, quite an expensive combination. So that's a major barrier for people to access this. Now, there hasn't been tremendous scientific research, but certainly some preliminary research suggests that it can be helpful.
Great. And we know there's a lot of overlap between some of the autoimmune disorders and people who struggle with migraine. Many of those people with autoimmune disorders are already on biologics or the anti-TNF and anti-interleukin medications. Is there any data or is there any contraindication of taking a CGRP along with those medications?
It seems fairly clear that it's okay. The antibodies we use for migraine are very specific. They just target the CGRP and they don't interfere with what the other treatment is doing for their other condition. So yes, there is some concern about that, but it seems to be all right.
Great. And you mentioned very little side effects other than maybe some allergies and otherwise matching that of placebo. There's no link to any sort of immune concerns like we see in some of the other biologics?
No, these antibodies don't affect the immune system itself. Now, by now, literally hundreds of thousands of people have had these antibodies, especially in the US. And if you go on the internet, you'll find all sorts of reports of side effects. You never know how much they are actually related to the medication. I might mention that constipation is an issue with some of these medications. So people have to be aware of that and take measures to prevent constipation. This is an issue, especially if they're taking other medications which can cause constipation. Things have been reported like hair loss, for example, and all those things. They must be very unusual. Now, people are concerned that patients who have had recent heart attacks or strokes, they shouldn't be taking these things because CGRP is involved in control of the blood vessels. And that's probably good advice. In the clinical trials where these medications were tested for migraine, patients who'd had sort of recent heart attacks or strokes or things like that, they were not put in the study, they were excluded.
Okay, and you mentioned the constipation. Is that related to dosage? The higher the dosage, the higher the risk?
Well, it might be. It seems to be a very individual thing. Constipation is a problem really in quite a minority of people who get these things. So it's a very individual thing. Higher doses probably are a factor. The fact of the matter is that CGRP is present not only in the pain system, it's also present in the gut, where it's involved in gut motility or movement. And that's likely why some of these medications will cause constipation. But again, it's not a big deal for most people. It's just something to watch out for.
Okay. You talked about the prevent protocol for Botox. With Botox itself, it's every 3 months. Is that something that goes for life?
Well, it's a good question. The hope is that some people can get off it because their migraine kind of settles down over time. And that does happen. I think it depends in large part upon how bad your migraine is and how long you've had it for. There's some evidence that if you can start Botox fairly soon after a patient develops chronic migraine, a headache on 15 days a month or more, then in fact, those patients can eventually get off it. But if they've had chronic migraine for 15 years, it seems to be much more difficult to get patients off their migraine, but off the Botox. But migraine does, change over time and fluctuate. So sure, some patients can get off the Botox.
Great. And, there's a lot of movement right now in the rheumatology world of trying to skip all the steps to get to some of the biologics as they prevent degeneration of joints and so forth. And they also seem to work better if you get them quicker. You mentioned the same thing with the current CGRP inhibitors. Is there any movement to, 80% of people in that trial had dropped out of the trial? Is there, or well, they stopped the medication, the people who stopped 80% because it either wasn't working or side effects. Is there any movement to see the CGRPs moving up to being more accessible?
So that 80% that you mentioned, that's 80% of those who stopped, and only 37% stopped in the first 6 months. But it's still it's a significant, an important factor. So I think we have to call the elephant in the room what it is, and the main issue is cost. If I were a migraine sufferer and had a really bad migraine, I would like to skip the oral preventives, but of course they're so much cheaper. Right. And so for most insurers aren't going to pay for them unless you really, really need them and have failed the simple stuff, the inexpensive stuff. I think this is something which migraine sufferers could look at carefully and lobby for, that maybe migraine sufferers should get the best stuff first. And in fact, I recently saw a scientific paper that did a bit of an analysis on this and suggested that, in fact, we should try the best stuff first. The only reason that doctors now really can't do that is because the new good stuff costs so much more.
Of course. I guess the big question then, there's things like abdominal migraine. There's also other types of headaches. Do these CGRP inhibitors have any effect on other types of headaches or in the so-called abdominal migraine?
I'm not aware of research with abdominal migraine. Dr. Leroux may know something about whether that's been reported. In terms of other headache types, the main ones where I think they can be useful, and that applies to both Botox and the CGRP antibodies, would be post-traumatic headache. Headache that develops after head trauma or migraine that becomes much worse after head trauma. These medications seem to be helpful in those situations. But having said that, the big important scientific clinical trials have only been done with migraine.
Okay.
I should emphasize, though, Rob, that if I may, that the CGRP mAbs, the CGRP antibodies are used in both chronic migraine and episodic migraine. If you have more than 4 headache days a month, you're possibly qualified for these. I didn't perhaps emphasize that enough.
Well, that is excellent to know. And I guess the big question is, any new medications on the horizon?
Well, there's a new acute medication on the horizon called lasmiditan, which isn't going to come to Canada for a while because Health Canada had a disagreement with the manufacturer. In terms of new preventive medications, yes, there are new CGRP antagonists coming that are not antibodies. They're the usual small molecule drugs. They can be taken orally by mouth. And I think they will come here probably within the next year or so.
Perfect. Well, I truly appreciate your time. I know there's a lot of other questions, but we're running tight and we'll have to move on. So again, Dr. Becker, thank you so much, both for being on the planning committee and helping put this all together. As most people know, Dr. Becker is also on our board of directors, as we've really tried to look at the reality that headaches and migraines are also pain, And so we appreciate your incredible expertise and wealth of knowledge. And from there, I'm excited to pass it over to either Christelle or Elizabeth. I wasn't sure which one, so I'll hand it over to Elizabeth.